Welcome back to the Deep Dive. Today we are tackling a really serious topic, a condition that, well, it gets called the flesh-eating bug disease sometimes, and that's not really hyperbole.
No, it really isn't.
We're doing a deep dive into necrotizing soft tissue infections, or NSTI.
Yeah, and this is, it's the definition of a medical emergency. NSTI isn't common, thankfully, but when it happens, the speed and the severity are just, well, frankly, terrifying.
Right.
Historically, you're looking at mortality rates that could go as high as 76%.
Right.
Think about that. Even with patients getting immediate aggressive care.
76%. Wow.
When something moves that fast, there's just no room for error. None.
And that kind of terrifying statistic, a potential 3 out of 4 chance of dying, it naturally pushes the medical world to find anything that might help.
Absolutely. Anything to stack the deck in the patient's favor.
And that brings us to the focus of our deep dive today. One of the most debated potential extra treatments, hyperbaric oxygen therapy, or HBO.
Right, HBO. So basically, you're putting the patient in a special chamber and giving them 100% oxygen under high pressure.
Right.
And, logically, it kind of makes sense, right? You've got tissue dying because it's starved of oxygen by the infection.
So flood it with oxygen. Seems intuitive.
Exactly. But the medical community is actually really divided on whether it truly works for NSTI.
And that division is pretty stark, isn't it? You've got major groups on opposite sides.
It really is. On one hand, you have influential bodies like the Infectious Disease Society of America. They look at the evidence, see a lack of those, gold standard randomized controlled trials.
The RCTs.
Right, the RCTs. And because those aren't there for NSTI and HBO, they actually recommend against using it routinely. They stick to that very high evidence bar.
Okay, so one side says, show me the perfect trial or don't use it.
Pretty much. But then on the other side, you have strong expert consensus groups. Like there's one from China, for example, where they've got a lot of clinical experience with this.
And what do they say?
They strongly recommend HBO. They see it as a necessary part of the whole package of care for NSTI. So you've got this clash between the need for perfect evidence versus clinical experience and, frankly, things like cost, availability, and how much weight you give to studies that aren't RCTs.
Right. So our mission today is to try and, cut through some of that noise. We found a really significant piece of research, a major systematic review and meta-analysis from 2023, published in the World Journal of Emergency Surgery.
And this wasn't a small effort. They pulled together data from 23 different observational studies.
23 studies. And the number of patients is just staggering.
It really is almost 50,000 patients in total across these studies.
Wow.
So we're going to unpack what this massive analysis of nearly 50,000 people tells us about HBO. Does it actually improve things like survival? Does it reduce complications? And crucially, why is there still such a debate?
Okay, let's start by just really painting a picture of NSTI itself. For anyone listening who maybe hasn't encountered it much, what exactly is happening in the body? Which tissues are under attack? And how fast does it really move?
Right. So NSTI targets the deeper layers of soft tissue. We're talking about the skin, yes, but more importantly, the tissue just underneath it, the subcutaneous tissue, and critically, the superficial fascia.
Fascia, that's the connective tissue layer.
Exactly. It's like this thin sheet that covers muscle groups. And the real danger with NSTI is that the infection spreads along these fascial planes like wildfire. It can travel really fast, and sometimes the skin on top looks almost normal initially until it's far too late.
That disconnect between surface appearance and deep damage sounds terrifying. And the speed, you mentioned speed, that's really the hallmark, isn't it?
It is absolutely the defining feature. The studies estimate that the area of dead or necrotic tissue can expand at about 2 to 3 centimeters per hour. Per hour. Yeah. So think about that over, say, 12 hours. That's 24 to 36 centimeters. That's almost a foot of tissue potentially destroyed.
Before someone might even get to the right kind of hospital or realize how bad it is.
Precisely. It's that time compression. Every single minute counts in terms of saving tissue, saving limbs, saving lives.
So when a patient does present, what are the signs that make a doctor think, uh-oh, this could be NSTI? What are those severe features?
You're looking for signs that suggest the problem is deep and that the body is starting to react systemically. Locally, the tissue might look grayish, dead-looking. There's often intense swelling. And importantly, the pain is frequently way out of proportion to how the wound looks on the surface.
Pain disproportionate to appearance. That's a key clue.
A very key clue. You might also see this thin, watery, really foul-smelling fluid coming from the site. Sometimes it's called dishwater fluid. And critically, what's happening underneath is that the infection is causing tiny blood vessels to clot off, to thrombose.
Cutting off the blood supply.
Exactly, which creates this low-oxygen, hypoxic environment, which unfortunately is the perfect breeding ground for some of the worst types of bacteria involved.
And once that local fire starts, it quickly becomes a whole-body crisis, right?
That's right. The local tissue destruction releases toxins, bacteria get into the bloodstream, and the body spirals downward very quickly. You see septicemia bacteria in the blood, infectious shock where blood pressure plummets, and then multiple organ dysfunction syndrome, or MODS.
MODS, basically the body shutting down.
Yeah, critical organs like the kidneys, the lungs, the liver start failing. And if you can't stop that cascade, the end result is often limb loss or, tragically, death.
So given that severity and speed, the standard of care has to be just maximum attack immediately.
Yeah.
Can you walk us through those pillars of treatment? Surgery seems central.
It is absolutely central, and it has to happen now. The standard approach really rests on 3 pillars, all deployed simultaneously without any delay. Pillar number 1, urgent, aggressive, and comprehensive surgical debridement.
Debridement meaning cutting away dead tissue.
Exactly. You have to physically remove every single bit of infected or dead tissue, cut back until you reach healthy bleeding tissue. And this often isn't a one-time thing. Patients frequently need multiple trips back to the operating room.
Wow.
Leaving even a small pocket of necrotic tissue is like leaving fuel for the fire. It's just non-negotiable.
That sounds incredibly challenging for the surgeon. Making those calls in real time, knowing how fast it's spreading, deciding what to cut.
It's one of the toughest surgical challenges, absolutely. A real-time assessment under immense pressure. Okay, so pillar 2 is equally urgent. Aggressive, broad-spectrum antibiotics given intravenously.
Broad spectrum because you don't know exactly which bugs are involved initially.
Precisely. NSTI is often caused by a mix of bacteria-aerobic ones that use oxygen, anaerobic ones that hate it, sometimes even fungi. So you need antibiotics that cover all the likely culprits, started immediately.
Okay, surgery and antibiotics. What's the third pillar?
The third is intense supportive care, usually in an intensive care unit, an ICU. This is about managing the shock, the massive fluid shifts that happen, supporting the organs that are starting to fail, basically keeping the patient alive while the surgery and antibiotics fight the infection directly.
And the sources really emphasize timing, don't they?
Yeah.
Missing that window is catastrophic.
Absolutely critical. If you miss that optimal window for surgery and starting antibiotics, even the best additional therapies later on are likely to fail. Time is everything.
Now, looking at this huge group of patients in the meta-analysis, almost 50,000 people did a typical patient profile emerge. Who tends to get NSTI?
Yeah, the profile was pretty consistent with what we generally know about risk factors.
Yeah.
The typical patient was often an older male. The data showed about 65% were male, and the average age was over 50.
Older males. Does that tie into underlying health conditions?
It does. That demographic often has more of the underlying conditions, the comorbidities, that make someone more susceptible to this kind of devastating infection.
And speaking of comorbidities, the analysis highlighted one condition above all others as being incredibly common and dangerous in NSTI patients. That's diabetes mellitus, right?
Absolutely. Diabetes was the dominant comorbidity. It affected over half the patients in this huge meta-analysis. And the link between diabetes and NSTI is, well, it's biologically devastating. There are a couple of key reasons why.
Okay, what are they?
First, high blood sugar hyperglycemia literally provides food for the bacteria. Glucose is an excellent energy source, so high levels in the tissues basically create this rich soup, this perfect culture medium that helps the bacteria multiply incredibly fast.
So it's like throwing gasoline on the fire.
Exactly.
Yeah.
It accelerates the whole process, but that's only half the problem. The second part is what diabetes does to the immune system.
It weakens the response.
Severely. High glucose levels impair the function of key immune cells, especially phagocytes, the cells that are supposed to engulf and destroy bacteria. They become sluggish, less effective. Their killing mechanisms don't work as well.
Wow. So more fuel for the bugs and a weaker defense force trying to fight them.
Precisely. It's a terrible combination.
Yeah.
It dramatically accelerates the infection's progression and is a major reason why diabetic patients with NSTI tend to have a much worse prognosis and higher mortality rates.
The source material mentioned a specific target for blood sugar control, trying to keep it below 10 millimoles per liter. Is there a reason for that specific number? Does immune function improve below that level?
Yeah, that threshold seems to be quite important clinically. Studies suggest that getting blood sugar down below that 10 millimole mark helps restore some degree of normal function to those key immune cells, the neutrophils. It also reduces that free lunch effect for the bacteria. So tight glucose control in the acute phase is actually a really critical part of that supportive care pillar we talked about. It's one of the few internal factors clinicians can directly influence quickly.
Makes sense.
Yeah.
Beyond diabetes, what other common health problems showed up frequently in these patients?
Well, we also saw high rates of hypertension, high blood pressure, which often means underlying vascular issues. Alcoholism and smoking were common too. Both of those impair blood flow to tissues and hinder healing.
Okay.
Obesity was another factor. It can increase tissue pressure and inflammation. And then things like chronic kidney disease and peripheral vascular disease, both of which severely compromise blood flow and oxygen delivery, especially to the limbs. All these things stack up, making the patient more vulnerable and less able to heal.
Okay, so we've established NSTI thrives in a low oxygen environment created by the infection-blocking blood flow. So intuitively, adding more oxygen with HBO seems like it should help. Let's dig into the mechanics. What actually happens inside that high-pressure chamber? How does it change oxygen delivery?
Right. The core principle is using physics to bypass the biological problem. So in an HBO chamber, you're breathing 100% oxygen, but critically, it's at a much higher pressure than normal air pressure, often around 0.2 megapascals or MPa above atmospheric pressure.
Okay, high pressure, pure oxygen. What does that do?
Under that increased pressure, the amount of oxygen that dissolves directly into the liquid part of your blood, the plasma, increases massively. We're talking about something like 17 times the normal amount of dissolved oxygen.
17 times. Not just bound to red blood cells, but dissolved right in the plasma.
Exactly. Normally, most oxygen is carried by hemoglobin in red blood cells, but in NSTI, those tiny blood vessels, the capillaries, are blocked or damaged. Red blood cells can't get through effectively.
So the normal delivery route is shut down.
Right. But this huge load of dissolved oxygen in the plasma can bypass those blockages. It can still reach the tissues. The sources estimate this leads to about an 8-fold increase in oxygen levels in muscle tissue and about a 4-fold increase in general tissue oxygen levels.
So instead of relying on the blocked roads, the oxygen is kind of parachuting in directly from the plasma, and because there's so much of it, it reaches further?
That's a great way to put it, yeah. The high concentration extends the diffusion distance. It forces oxygen deep into those injured, swollen, oxygen-starved tissues that normal blood flow just can't supply anymore. This helps stop the immediate tissue death, the necrosis, from spreading further.
Okay, so it directly counteracts the hypoxia. But you mentioned other benefits too, right? Anti-infective effects.
Yes, absolutely. The high oxygen does more than just keep tissue alive. It actively fights the infection and helps with healing in several ways. We can probably break it down into about 4 key areas.
Okay, let's hear them.
First, and maybe most directly, it has a bacteria-killing effect. Many of the really nasty bacteria involved in NSTI are anaerobes. They thrive in low oxygen conditions.
Oxygen is poison to them.
Exactly. Flooding the tissue with high levels of oxygen generates oxygen-free radicals, which are highly toxic to these anaerobic bacteria. It turns their preferred environment against them.
Nice. Okay, what's second?
Second, HBO boosts the body's own immune response. Our white blood cells, particularly neutrophils, need a lot of oxygen to work effectively, especially for the process of phagocytosis, where they engulf and destroy bacteria. By dramatically increasing tissue oxygen, HBO basically supercharges these immune cells, making them much better fighters.
Okay, so it kills the bad guys directly and helps our own troops fight better. Good combo. What else?
Third, it helps with wound healing and tissue repair. High oxygen levels stimulate the activity of fibroblast cells that produce collagen and help build new tissue. It also promotes angiogenesis, the growth of new blood vessels into the damaged area. This is really crucial for the longer-term recovery and reconstruction process.
Makes sense. Need to rebuild after the battle. And the fourth point?
Fourth, it seems to help reduce the overwhelming inflammation and the flood of inflammatory chemicals or cytokines that contribute to the systemic crisis. By calming down this inflammatory storm and creating a healthier tissue environment, it may act as a barrier, helping prevent the local infection from spiraling into that deadly systemic shock and MODS. Reducing that systemic toxicity is key.
Okay, so listening to all that, kills bacteria, boosts immunity, promotes healing, reduces inflammation. It really does sound like a perfect weapon against NSTI.
Theoretically, yes. The biological rationale is incredibly strong.
But, as we said, there's this controversy. Major medical societies are hesitant. If the science behind how it should work is so clear, why the reluctance? What's the sticking point?
The sticking point comes down to the type of evidence. It's purely about scientific rigor and evidence hierarchies. Biological plausibility, the it should work argument, isn't the same as clinical proof that it does work consistently in patients. And the specific issue is the lack of published, large-scale, prospective, randomized controlled trials, those RCTs again, the gold standard. Without RCTs definitively showing that HBO improves hard outcomes like mortality or wound healing rates in NSTI patients.
Compared to patients who didn't get it, under controlled conditions.
Exactly. Without that level of proof, organizations that prioritize the absolute highest level of evidence hesitate to recommend it universally, especially given that HBO isn't cheap, it requires specialized facilities, it's not available everywhere.
So they demand that gold standard proof before making it a standard recommendation.
That's the core tension. We have a really compelling theory and mechanism, but until this big 2023 review tried to pool all the existing observational data, the clinical evidence was seen as too fragmented or not robust enough by some key groups.
Okay, so let's turn to that 2023 meta-analysis itself, the one trying to bridge this gap between theory and proof by pooling existing data. It included 23 studies. How widespread was this research? Where did the data come from?
The scope was genuinely global, which is a real strength. It reflects that NSTI is a worldwide problem. The researchers gathered 23 retrospective studies. These were mostly case control or cohort studies.
Meaning they looked back at patient records rather than setting up a forward-looking experiment.
Exactly. And these studies came from all over: North America, Europe, Asia, South America, even Oceania. So it wasn't just looking at practice in one specific region, which helps make the findings potentially more generalizable.
And the number of patients, we mentioned nearly 50,000. Can you give us the breakdown again? It's just such a large number for a rare disease.
It really is impressive. The total was 49,152 patients. Out of those, 1,448 patients had received HBO therapy as part of their treatment.
Okay, about 1,500.
And the comparison group, the non-HBO group, was massive, 47,704 patients.
Wow.
For a condition like NSTI, rare, complex, incredibly lethal, having data on almost 50,000 cases gives you a lot of statistical power to detect patterns, even if the individual studies weren't perfect RCTs.
So when the researchers started analyzing this huge data set, what were they specifically looking for? What were the main outcomes they measured?
They had a very clear focus. The number one thing, the primary outcome, was the most important one: mortality rate. Did the patient live or die? Simple as that.
The bottom line.
Absolutely. Then they looked at several secondary outcomes, which focused more on the recovery process and complications. These included things like the average number of debridements, how many surgeries were needed, the amputation rate, did the patient lose a limb, and the rate of specific serious complications.
Which complications did they track?
They specifically looked for things indicating systemic collapse, multiple organ dysfunction syndrome, MODS, sepsis, shock, and also other serious events like myocardial infarction, heart attack, pulmonary embolism, blood clot in the lung, and pneumonia.
Okay, comprehensive list. Now, we've hyped the massive size of this study, but we have to hit the brakes here and talk about the big limitation. 23 studies, all retrospective. What does that mean for how certain we can be about the findings? How does the medical world rate this kind of evidence?
Yeah, this is absolutely crucial. It's the big asterisk next to all the findings. Because all the included studies were retrospective, looking back at data collected for other reasons, without researchers controlling who got which treatment or when the evidence generated is considered inherently weak by modern evidence standards.
Weak evidence, but from a huge number of patients. That's an interesting mix.
It really is. The researchers formally assessed the evidence quality using the grade system. That's a standard tool for rating certainty. And their assessment for the key outcomes, mortality, amputation, number of debridements, came back as low or very low certainty.
Low or very low. So what does that practically mean?
It means that even though the analysis might show a statistically significant difference between the groups, we have to acknowledge there's a real possibility that future research, especially if someone could ethically conduct a high-quality RCT, might come to a different conclusion. The results could change.
So we need to be cautious. Even with 50,000 patients, the retrospective nature means we can't be 100% sure that HBO caused the difference. Maybe the patients who got HBO were different in some other important way.
That's the core issue with retrospective studies, the risk of bias. Selection bias, maybe less sick patients tended to get HBO, or treatment bias, maybe the centers offering HBO also had better overall care. You can try to adjust for some factors statistically, but you can never eliminate all that potential bias.
Right.
However, the authors of the review make a really important counterpoint. Doing a proper RCT for NSTI, where you'd randomly assign critically ill patients to either get or not get a potentially life-saving therapy like HBO, well, that's ethically incredibly difficult, if not impossible.
Yeah, you can't ethically withhold a treatment you strongly suspect might help someone who's dying right now just for the sake of a clean experiment.
Exactly. So in situations like this, large, well-conducted meta-analyses of the best available observational evidence, like this one, often become the most practical source of guidance, even with their inherent limitations. It might be the best evidence we can ethically get.
Okay, let's dive into the results then, keeping that low certainty caveat in mind. The primary outcome was mortality. Given the scale here, what did the analysis find about survival? Was there a difference?
Yes, there was. And it was a really strong signal. The headline finding is that the mortality rate was significantly lower in the group of patients who received hyperbaric oxygen therapy compared to those who didn't.
Significantly lower. How much lower are we talking?
Let's look at the numbers again because they're quite striking. In the non-HBO group, the average mortality rate was 25.6%. So about 1 in 4 patients died.
Okay, still tragically high.
Very high. But in the group that received HBO, the mortality rate dropped to 10.6%.
Wow, from 25.6% down to 10.6%. That's a huge difference, more than halved.
It's a massive difference, a reduction of 15 percentage points. The study calculated the relative risk, or RR, as 0.522.
Can you break down that relative risk number for us? What does 0.522 mean practically?
Sure. An RR of 0.522 means that patients who got HBO had roughly half the risk of dying from NSTI compared to patients who didn't get HBO. Or, put another way, their risk of death was reduced by about 48%.
Half the risk of dying. When you're talking about a condition this deadly, that's not a small effect. That seems clinically massive.
It is. I mean, think about discussing this with a patient's family in the ICU. Being able to say, adding this therapy appears to cut the risk of dying roughly in half, from about 1 in 4 to 1 in 10. That's a profound potential benefit. It goes way beyond just statistical significance.
It seems like even with the limitations of the retrospective data, the sheer volume of patients allowed this strong signal to emerge.
That seems to be the case. The authors suggest this large reduction in death likely stems directly from those multiple mechanisms of HBO we discussed earlier.
Right? Increasing oxygen, fighting bacteria.
Exactly. By boosting oxygen diffusion, it helps stop the necrosis from spreading, essentially containing the fire, giving surgery and antibiotics a better chance. By reducing the systemic toxicity and maybe helping the immune system, it prevents that deadly cascade into total organ failure, which is ultimately what kills many of these patients.
Now, was this survival benefit seen across the board? Or was it specific to certain types of NSTI, like the Fournier's gangrene you mentioned?
That's a really important question, and they looked into it with subgroup analysis. They specifically compared the effect in patients with Fournier's gangrene, that's the NSTI, affecting the genital and perineal area, often linked to diabetes versus other types of NSTI.
And what did they find? Did it hold up?
It did. The mortality benefit was statistically significant in both groups. For the Fournier's gangrene subgroup, the effect was actually even stronger, with a relative risk of 0.389.
So even less likely to die in that specific group if they got HBO.
Correct, almost 2.5 times less likely. And the benefit was also clearly there for the non-Fournier's gangrene group as well, with an RR of 0.580.
Okay, so that suggests the benefit isn't just localized, it's a more general effect of the therapy against the disease process.
Yeah, it strengthens the argument that the superoxygenation provides a systemic advantage against the infection, regardless of the exact location.
Right, survival is the big one. What about complications? The goal is not just to survive, but to survive without catastrophic organ failure. Did HBO help prevent specific complications, especially that deadly MODS?
Yes, this was perhaps the clearest secondary finding, and it really supports the mortality result. They found that the incidence of multiple organ dysfunction syndrome, MODS, was dramatically lower in the HBO group.
How much lower?
The relative risk for developing MODS was incredibly low, just 0.205.
0.205, wait, I mean, an almost 80% reduction in the risk of developing MODS.
Exactly, an 80% reduction. That is a staggering difference.
Wow. That seems to directly explain the survival benefit then. If you prevent MODS, you prevent death in many cases.
It strongly suggests that's a key mechanism. By getting oxygen to those struggling tissues quickly, HBO seems to interrupt that devastating chain reaction where the body's own inflammatory response spirals out of control and causes widespread organ damage. Preventing MODS is critical.
So a huge win for preventing MODS.
Yeah.
But did it help with all the complications they measured? Sepsis, shock, heart attacks?
Interestingly, no. The benefit seemed quite specific to MODS. The analysis found no statistically significant difference between the HBO and non-HBO groups for the rates of other complications like sepsis overall, shock, myocardial infarction, pulmonary embolism, or pneumonia.
So it didn't reduce the risk of getting sepsis, for example, but it drastically reduced the risk of that sepsis progressing to full-blown multi-organ failure.
That appears to be what the data suggests. The protective effect seems really focused on preventing that final fatal step, the transition from severe infection and shock into the irreversible failure of multiple organ systems. That's where HBO seems to make the biggest difference, according to this analysis.
Okay, so we've got HBO linked to significantly better survival and a dramatic reduction in MODS. Clear wins. But now we get to some secondary outcomes where things get, well, a bit confusing. Let's talk about the number of debridements. Logically, you'd think a treatment that helps control the infection would mean fewer surgeries, right?
You'd absolutely think that. Better control, less dead tissue, fewer trips to the OR. Makes sense.
But the study found the opposite.
Yes. This is where things seem counterintuitive. The analysis actually showed that the number of surgical debridements performed was statistically higher in the group that received HBO.
Higher? How much higher?
The difference was measured using something called the standardized mean difference, or SMD, which was 0.611. Basically, it confirms the average number of surgeries was significantly greater in the HBO group.
Okay, so the group that survived more often also had more surgeries. That seems paradoxical. How do the researchers explain that? Why would the successful group need more operations?
Right, it's a puzzle on the surface. But the source material offers a couple of really plausible explanations. The first, and probably the most important one, is something they call the survival paradox.
The survival paradox. Okay, explain that.
It's actually quite straightforward when you think about it. Patients who survive longer simply have more time to undergo more treatments. If patients in the non-HBO group were more likely to die quickly from overwhelming sepsis and MODS, maybe within a few days, they just didn't live long enough to have multiple staged debridement surgeries, which are often planned over weeks as the wound evolves.
So the patients getting HBO survived the initial crisis, meaning their treatment course was longer, which naturally included more surgical procedures for cleanup and reconstruction.
Exactly. The higher number of surgeries in the HBO group might actually be a sign of success. These patients lived long enough to require that ongoing surgical management. If you just count surgeries without considering survival time, the non-HBO group might look better, simply because their treatment was tragically cut short by death.
That makes a lot of sense. So using the number of debridements as a measure of whether HBO is working is potentially really misleading.
Highly misleading. The researchers basically concluded that the number of debridements is an inappropriate metric for judging HBO's effectiveness in this context.
Okay. Was there another potential explanation offered for the higher surgery count? Something more logistical?
Yeah, there was a second point raised. It's possible that different hospitals or studies included in the analysis might have counted procedures differently.
How so?
Well, some might have counted taking small tissue samples for lab testing, for cultures to see which bacteria are present as a formal debridement procedure, even if it wasn't a major tissue removal. If the centers using HBO happen to have more rigorous protocols involving frequent sampling.
That could artificially inflate their count of surgeries.
Potentially, yes, without reflecting the actual amount of tissue being removed.
Okay, so between the survival paradox and potential counting differences, the conclusion on debridement numbers is?
The strong conclusion from the source is, don't use the number of debridements to judge HBO in NSTI. It's not a reliable or meaningful measure of efficacy here. They recommend future research should focus squarely on survival, long-term outcomes, and quality of life, not intermediate process measures like surgery counts.
Makes sense. Okay, let's move to the other big secondary outcome, amputation rate. If HBO is supposed to be forcing oxygen into dying tissue, did it help save limbs? Did we see fewer amputations in the HBO group?
This is another area where the hope didn't quite match the data, unfortunately. Despite the clear survival benefit, the analysis found no statistically significant difference in the amputation rate between the HBO group and the non-HBO group.
No difference at all.
Essentially none. The relative risk was 0.836, but the confidence interval crossed 1.0, meaning the result wasn't statistically significant.
So HBO seems to help people survive the systemic crisis, but it doesn't necessarily prevent the local tissue destruction from progressing to the point where amputation is still needed.
That seems to be the implication. It suggests that by the time many NSTI patients get diagnosed and treatment starts, the damage, particularly in limbs, might already be too extensive. Even flooding the area with oxygen at that point might not be enough to reverse the process and salvage the limb, even if it helps save the patient's life overall. HBO saves lives, it seems, but doesn't reliably save limbs in this context.
Right. Lastly, on this section, what about the safety of HBO itself? Did adding this therapy introduce new problems or complications?
Based on the complication data, they tracked things like sepsis, shock, MI, PE, pneumonia. There was no sign that HBO increased the risk of those particular issues. So the general implication is that when done correctly by trained staff, HBO appears to be relatively safe in this patient population.
Relatively safe, but not entirely without risk, right? The sources mentioned potential side effects.
Oh, absolutely. It's a medical procedure, and it has known potential risks that need careful monitoring. The main ones are things like oxygen toxicity, which can, in rare cases, cause seizures. There's also barotrauma damage caused by the pressure changes, potentially affecting the sinuses, ears, or even lungs. And some patients experience claustrophobia or anxiety in the chamber, so it requires careful patient selection and monitoring.
Okay, so we've synthesized this huge analysis.
Okay.
We see a strong signal. HBO seems to cut mortality and MODS significantly in NSTI patients. But we also have this major caveat. The evidence quality is rated low to very low because it's all retrospective data.
Right, that's the fundamental tension.
So if the goal is to get clearer guidance, maybe reach a global consensus, what needs to happen next in terms of research? What are the big gaps this study highlights?
Well, the first step has to be trying to address the inconsistencies and limitations inherent in the existing retrospective data. We need to move beyond just pooling flawed studies if possible.
And a big part of that inconsistency was how HBO was actually given, wasn't it? The protocols varied wildly.
Hugely. That's a major limitation identified. The duration of each HBO session, the number of sessions given, the exact pressure level used. It was all over the map across those 23 studies.
So you can't really say this specific way of doing HBO works best.
Exactly. It makes it impossible to define an optimal protocol based on this data. So a crucial recommendation for future research is to establish unified therapy criteria. We need studies, maybe multi-center collaborations where everyone agrees on how they're going to administer HBO, the dose, the frequency, the duration, standardize the intervention first.
Okay, standardize the treatment protocol. What else? We talked about the problems with measuring things like debridement counts.
Right. The focus needs to shift entirely away from those potentially misleading intermediate markers. Future research must concentrate on meaningful long-term patient outcomes.
Like survival, obviously.
Survival rate is paramount, yes, but also we need long-term follow-up. What happens to these patients months or years later? What's their recurrence rate? What's their functional status, their quality of life? What are the long-term complications? Focusing on survival plus these long-term quality metrics will give us the evidence needed to make truly informed decisions.
And underlying all of this, even if HBO is helpful, the sheer speed of NSTI remains the biggest challenge, doesn't it?
Absolutely. That's the elephant in the room. Even with HBO apparently cutting mortality significantly, the death rate in the HBO group was still over 10%. That's still incredibly high. The fundamental problem is the rapid progression and the difficulty in diagnosing it early enough.
So improving early detection is key.
It's probably the single most critical area for improvement. Anything that helps clinicians identify NSTI faster, get the patient to surgery sooner, that will likely save more lives than any single adjunctive therapy, however effective it might be later on.
Okay, so let's try to pull this all together. We have this massive real-world data set showing a strong link between HBO and reduced death and MODS. But we also have the scientific purists rightly pointing out the evidence isn't gold standard RCT quality. So what's the critical takeaway? What should a clinician or a learner think after hearing all this?
I think the key takeaway is that clinical decisions, especially in high-stakes emergency situations, often have to be made using the best available evidence, even if it's not perfect.
Right.
Here, despite the acknowledged limitations of retrospective data, having nearly 50,000 patients showing such a consistent and large reduction in mortality and MODS with HBO, well, that's incredibly compelling evidence.
It's hard to ignore a signal that strong, even with the caveats.
Exactly. So, while we can't necessarily say the evidence mandates HBO use in all cases because of cost, availability, and those evidence limitations, the data strongly suggests that clinicians treating NSTI should seriously consider HBO as part of the multimodal treatment plan whenever it's available and safe to administer, particularly for high-risk patients like those with diabetes.
So it's a judgment call, but the evidence clearly leans towards using it if you can.
I think that's fair. It's a classic example where a strong correlation found in a large cohort addressing a condition with devastating consequences carries significant weight in clinical decision-making, even without that definitive RCT proof. The potential benefit seems substantial enough to often warrant its use in practice.
The signal is just too powerful, potentially, to ignore while waiting for perfect evidence that may never come.
Precisely. In these life or death scenarios, the data we have suggests the risk of not using HBO might well outweigh the risks or uncertainties associated with its use. Hashtag outro.
So this deep dive into that huge 2023 meta-analysis really seems to crystallize something important. For necrotizing soft tissue infections, this incredibly fast, incredibly deadly disease, adding hyperbaric oxygen therapy shows a strong, significant correlation with better survival.
Yeah, specifically by preventing that catastrophic shutdown of multiple organs, the MODS. It suggests that the underlying biology, the need for oxygen, might be speaking louder than the arguments about evidence purity here.
It highlights that difficult balance clinicians face, especially when RCTs are ethically challenging.
Absolutely. Prioritizing observed, large-scale positive signals in the most severe cases becomes crucial.
Which brings us to our final provocative thought for you, the listener, to consider. We see the strong link between HBO and saving lives in NSTI based on tens of thousands of patients. We also accept that doing a perfect randomized trial, where some critically ill people are denied HBO, is likely unethical. So how should the medical community move forward?
Yeah, how do you balance that urgent need for the highest quality evidence against these compelling positive results from the real-world data we do have?
Is this current low to very low certainty evidence, because of its sheer scale and the size of the effect, actually enough to say HBO should be standard wherever possible? Or should the focus pivot entirely? Maybe accept the survival data as suggestive but imperfect, and pour all future efforts into just standardizing the HBO protocols and rigorously tracking long-term quality of life in patients who receive it.
It's a tough question. Where do you draw the line when the evidence is ethically constrained, but the potential benefit seems so large and the cost of inaction is measured in lives?
Something to think about. Thank you for joining us for the deep dive.